about how many people we needed to talk to and how to approach them, and we were very fidgety, I remember. We had conference calls on, well, should we email them or should we just drop by, or if we should call them to see if they want to help us. And at the beginning we ended up calling them to see if we could email them about dropping by. And what you find is that people actually genuinely like to help. They like to be relevant to an exciting problem. So frame the problem in an exciting way. And when you finally get that meeting, don't get too excited about your idea. Ask the questions that you need to ask, but listen, and listen actively. As you're developing these ideas, look at how your users improvise. There's often an invention hidden in that solution, waiting for just a little bit of engineering sprinkled to make it happen. Look at how people are mashing up old and new devices in the developing world. And again, it's not just about what you can cook up in the lab. I don't care if it's your thesis or your doctoral dissertation. You have to make sure they need it. And this is an exciting field. I think that there's a lot of questions out there. We still don't know a lot about how to do this, but the fact that it's so new allows us to make a big impact. When I joined D-Lab at the beginning of 2005 and just doing projects, this is basically my network. I had some experience in international development through the World Bank, obviously school. I got a Rotary scholarship. That was sort of my way of meeting business people and that sort of thing. And then when I developed these projects, very quickly, this grew to something that looked like this. And it was very interesting because you go from knowing a couple of people at one institution and a couple of people at your old job to knowing 50, 100 people across the nation in Europe and now in Japan. And that's really, really exciting because it scales up your ability to do things. I'm going to now jump into more specific technologies focusing around health, which is my area of specialization within the lab. 90% of medical devices in the developing world are donated. You see them every week in the newspaper where somebody donates medical equipment to a place like Honduras. And the problem is that most of them are used, and the stats tell us that 80% of those donations fail within 6 months. The problem is they were never designed to work there. They were designed to work here in Tokyo, or in Munich, or in New York, not in Managua, Nicaragua, or Totogalpa, or places where you don't have running water, you don't have adequate training, you may not have electricity, or if you have electricity, it's going to fluctuate between 120 volts and 400 volts every once in a while. So how do you design devices that actually can be useful for doctors and patients around the world? One of the things you don't do is you don't do the stripped down version. You need to attack the problem, just like Land Rover attacks the problem of going through a jungle. And so what I like to say is we don't make devices that are the Kia version of the medical device. We like to use the Land Rover version. And I'll give you some examples of how we're attempting to do that. IIH is a cluster of labs around the world, not just at MIT, that have been federalized and affiliated to work together, very much in a neighborly fashion. It becomes very relational. I have 3D printers that maybe Kathy Clapperidge at Boston University doesn't, but she has lab-on-a-chip devices that I don't. And we collaborate. And one of the things that I'm excited about coming into Japan is figuring out how we can collaborate with your resources and my resources and have a better impact on this side of the world and maybe my side of the world as well. These are the types of things that we're working on. It's vaccines, we're doing disability technologies, diagnostics, information systems, surgical tools that are better suited for working in extreme environments. I don't know if you can see the map, and these are the different places where we're working at. The red dots illustrate laboratories that we have some sort of activity on. There's a PI there, there's a collaborator, there may be a clinical trial. And the blue dots are 3 centers of excellence that we've identified. One's at MIT, one's in Managua, Nicaragua, where I'm flying to on Monday, and one's in Karachi, Pakistan, which is a clinical trial center where we're doing some of our tuberculosis work. We're about 2 years old. Again, there's about 12 country sites in addition to the 3 centers of excellence. There's about 20 principal investigators affiliated with IH, and about 22 technology projects and a few clinical trials going on at any given time. One of the things, again, speaking to that Land Rover version, is if you notice, it's not just about making it cheap. It's about making it right. And when we design for the developing world, specifically in health, we have to look at specific parameters that are going to make these devices sustainable. And one of the ones that we're working on very, very hard is, in addition to local manufacturing, which is a pretty big challenge, we're trying to empower local innovation. You know, a lot of these doctors out there are hacking their own devices, figuring, because of pure necessity. They're using duct tape or maybe medical gauze to really just jerry-rig some things that nobody's invented yet, but they just have an idea to basically save that patient's life. We're trying to access those doctors, identify them in the developing world, map their innovation flow, and give them tools so that they can become better designers. Sorry about the font here. I'll translate the numbers. There are not 40 measles cases in the world. There's about 40 million measles cases. Deaths have fallen. They're less than 500,000 now, but it's still substantial. The problem is that UNICEF still spends about $500 million just on this disease alone. And the design, the device of choice is the needle syringe. It's a simple design. Everybody knows how to use it. The problem is that they don't use it correctly. Needle syringes are responsible for about 250,000 cases of HIV. And about almost 2 million cases of hepatitis around the world. According to our experts at UNICEF, 1/3 of all injections in the developing world are unsafe. And it's illustrated by this little boy here, who in Nigeria is paid to scavenge for dirty needles in dump yards, and collects them, and then a pre-processor invests money into a machine that repackages them and cleans them and sells them as new. And I've been given these needles at UNICEF, and I can't tell the difference between the BD needle and the needle that came out of the junkyard, and that's really scary. So instead of spending a lot of time trying to figure out how to train people to use needles and how to do capacity building programs, which are going to do their work eventually, we tried to sidestep the issue and say, why don't we make a better device that will deliver vaccines, in this case, for measles, and also eliminate the hazards of needles. And one of the approaches that we looked at was inhalable drug delivery. But we needed to do it in a way that was suitable for the developing world. So first, we identified the engineering challenge. And our goal was to deliver using the existing vaccine without reformulating and having it to be resubmitted through the long process of FDA, using the existing injectable vaccine and aerosolizing it in a way that we could target a zone in the lung that was between 1 and 5 micrometers across. And then do it in a repeatable fashion, 30 doses at a time, and then do it in the middle of nowhere with somebody that might just have learned how to use the machine 30 minutes ago. And so one of the devices that we came up with is the AeroVax. The AeroVax can now deliver 700 doses of measles vaccine, and a user can travel 7 days without refrigeration or electricity. And it has redundant systems that allow them to basically treat the vaccine as if you were delivering an inkjet cartridge. Another device that we were working on with our collaboration at IH and people at Boston University is a SNAP device. And this is a device aimed at isolating DNA in the middle of nowhere. And it uses a combination of these thin polymer rods that took their inspiration from a microfluidic chip, and then the designer isolated the channel. And then you use a bike pump to add air pressure, and then there's a few washes of chemicals, and you end up with isolated DNA, which is a lot more stable than whole blood or urine when you need to transport diagnostics in the middle of nowhere. And tuberculosis is another issue that we've been working on. TB still affects a large number of people around the world, despite the fact that it can be cured. In 2005, there were about 8 million cases.